We're here at the IAS. We're here with Gus Cairns, who is with AIDSmap US, and that's from UK.
Yep.
And we appreciate you taking the time to visit with us. You've been doggedly looking at the research that's going on in cure, the cure work. There's no cure yet, but we're working on it. And if you could tell us about what you've learned here at this conference so far.
Yeah, I mean, I've been picking up on other things as well, because I specialise in prevention. So there's some good prevention news here as well, just come from the results of the partner study, which you may have heard about, which basically
what's the numbers? What are the
provide
numbers now?
More details about
80,000
people with undetectable viral loads really do not transmit. There's still no transmissions in this study from a positive partner to a negative partner if the positive partner is suppressed. You know,
the best person to have sex with is probably a person who's positive on treatment.
But if you're in a high incidence group like gay men, certainly. You know, and what it's done is basically they've got twice as much data, so they're able to narrow down the confidence intervals.
Right.
You know, so the outside biggest possible chance is something like 2% for unprotected anal sex if you're receptive, and without a condom the highest risk, whereas last time they ran through the data it was 4%, so that makes a difference. And she said quite firmly this time, and in the published text of the, we think it's zero. You know, they've actually finally sort of said that. And they also gave the number of what they call unlinked transmissions, which means the ones that come from other people, and it's 11, 10 in gay men, 1 in the heterosexual.
Yeah.
So that's interesting to know. But cure is very interesting, and also I'm hearing some interesting stuff on vaccines too. There's no breakthroughs, that's the first thing to say. Cure science is I would say it's the second stage. Until recently it's been at its first stage, which is really just trying all sorts of approaches, throwing them at the wall, seeing what sticks. You know. Now they're, I think, getting a sense of what might work and what might not work. And I went to the Cure Symposium on Saturday, Sunday.
The workshop.
And really, there was loads of stuff there. So many different studies. And there's still a multiplicity of possible approaches.
I think TAG had out a 2-page list. Did you see that, of all the work that's being done in the cure?
No, I didn't actually see that.
I'll get that
I did my own summary for the pre-conference to the pre-conference, as it were, which was the sort of community education bit that happens first. And I did one in the Global Village. And I mean, I think cure technology falls into roughly 3 possible broad approaches. So, one is actually physically removing all the HIV infected cells from a body, or all the cells that can be infected. And that's what they did with Timothy Ray Brown. So that's, you know, we have an N=1 example of
not a viable,
of a cure.
A scale up, not possible.
We still have that. Well, that's because if we're going to do it by means of a bone marrow transplant, you would only ever do it in somebody who needed one, because that's a fantastically risky procedure. And that was underlined by a study, and a cohort study they've got in Europe called Aspire, where they're recruiting positive people that this happens to. And so far they've found about 14 of them, and of those 8 have already died, because these are very, very sick people. You wouldn't do this to a healthy person. But it underlined the fact that there's a big synergy happening between cancer and HIV cures.
I've been seeing
They're starting to use the same drugs to do the same things to cells, and really, I've always said that an HIV cure in the end will look like a cancer cure, because in HIV, the viral DNA, the instructions for making a virus, get inside your genome. So the virus becomes much more intimately part of you than a normal virus does. And so an HIV infected cell is like a cancer cell. It's a cell that's gone rogue.
Right.
Except what it does is spits out virus instead of proliferates without control.
Right.
But it's the same issue. So that's technique number one, removing every cell in the body that might have HIV. Technique number two is ramping up the immune response to HIV. And they've tried this once with the sort of whole kick and cure, what they call the kick and cure, kick and kill, sorry, not kick and kill, kick and kill approach, where they try and stimulate the cells that are in the so-called reservoir that have HIV but are invisible to the immune system. So they give them a kind of chemical kick using cancer drugs which are designed to get cancer cells to come out of hiding. The idea originally was that if they came out of hiding, they might destroy themselves by turning into short-lived cells. This doesn't happen. That's one thing they found out. This doesn't work by itself. You need a sort of gene probe that targets those cells and kills them. So that's ramping up the immune system. And you can do that with other ways, like a therapeutic vaccine. You know, the CMV vaccine that is under investigation as a preventative vaccine could also be a cure vaccine. So that's ramping up the immune system. The other thing to do is to damp down the immune system. And that, I think, is the most interesting approach, but the one that's most difficult to imagine how you could get it to work in chronically infected people. This is what's happened to the Visconti patients and the Mississippi baby who were caught early on in HIV infection. You give them early antiretroviral therapy, and in some lucky people it suppresses their viral load down so low that the body forgets to notice that it has HIV. People become HIV negative.
But is that because their body hasn't been seeded sufficiently?
Yeah, or that you've actually, or that you are actually doing something that squashes the viral load down really, really low. And there was a really interesting study at the Cure workshop in young women in South Africa, the first piece of really frontier cure science done in a low-income setting, showing that it's feasible to do it here, where they did the same, actually no, the second piece, because this is based on a time model, where they tested young women twice a week for HIV. It's very high incidence, very high risk group of 300 young women. And so they could give them antiretroviral therapy within days of their infection. And in the ones where they did offer them and they agreed to take it, the majority of those young women have become HIV negative again, having been HIV positive. That doesn't mean they're cured, and there's an ethical issue about how you interpret that for
Well,
them.
they caught them within 2 weeks.
But they caught them before a big antibody response developed. And that might mean that when they take them off therapy, the body sort of simply fails to notice that there's a bit of HIV in the system and doesn't react. And so you don't get the immune cells that the body needs in order to, the virus needs in order to start reproducing. And that's a really interesting idea. So, and there are archetypes, there are phenotypes that, you know, the ramping up the immune system phenotype is the elite controller. These 1% of people that have hyper strong immune reactions to HIV that keep the virus in check. You know, and that works, can work for 20 years, but it's not good for them in other ways. They get high rates of heart disease, for instance. And the other one is to turn people into Visconti cohorts members or sooty mangabes that have high levels of HIV in their system, but their body simply doesn't react to it. It's essentially become a benign virus. So that's the other way. There was some bad news as well in the sense of negative studies. There was a study that's just been presented of using a cancer drug to stimulate the immune system, a malaria drug, chloroquine, to dampen it down again, and an antiretroviral to combine these together to see if you could flush the HIV out of the system. And it kind of did that, but it didn't have any effect on how quickly people started producing virus again if you took them off antiretrovirals.
Do you believe that that we actually have all of the pieces that we need to build to create the puzzle?
No. No, there are things we don't know. For instance, I'll give you an example. At the high-tech end is the idea of gene editing, which you may have heard of, where you use this amazing sort of gene probe thing to zoom into your cells via a sort of mock infection. It gets the T cells to incorporate this into their genome, so they actually produce this sort of extraordinary bit of cellular machinery. And what this does is that it consists of a probe that zooms in specifically to the HIV DNA inside the cell, and then added to that is an enzyme that snips that bit of DNA and degrades it, and then joins the frayed. No, actually, it's the human mechanism joins the frayed ends. So you can literally snip the HIV DNA out of the cell. And we had bad news recently because it was found that HIV became very resistant to the gene probes very quickly. But they've now found that if you do a combination of two of these probes, very similar to the early days of antiretroviral therapy, becomes resistant with much more difficulty.
It's always going to be that.
But they
dual.
have no clue what makes the difference between a gene probe that works and one that doesn't. There's no. So there's lots we still have to learn. And the biggest unanswered question is correlates of safety. Is a debate, really strong debate raging in the research community about when and whether it is ethical to take patients in cure studies off their antiretrovirals. When do you do that crucial step? You know, you've done something to them which you reckon might lead to them being able to control HIV without their antiretrovirals, but how do you know when to take them off? When's it going to be safe?
Because you're not going to be able to test them every 2 weeks.
Well, it's not that so much as they don't know what the surrogates are. They don't know what the markers are for whether they're going to be able to control HIV or not. And the trouble is you only get one shot at this, all right? If the person who is apparently virally suppressed with very low levels of virus, if it reappears, and it has done, we know it can do, then that's their only shot at it, because that means their reservoir gets seeded with HIV as it has not been before, and they essentially become sort of normal HIV positive people who will need long-term therapy. So that's their one shot. And equally, some of these drugs, the cancer drugs which are immune stimulants, may actually have harmful side effects as well. Some do. So there's a big ethical debate, and that was aired very strongly in the cure research. There's a big social science strand to it about how what should the criteria be? What do you tell people? What do you tell someone who may become HIV negative during the course of a cure study that they are not yet cured, for instance? Who decides when to take them off the drugs and when? In the case of the young South African women in the study I was talking about, they've decided to give it at least 2 or 3 years before they take them off, before they even offer them the chance to come off antiretrovirals.
Yeah, I guess it's not. I mean, why? But the drugs are not harmful for the most part.
No, that's the thing, because although there's a big synergy between cancer therapy and HIV cure therapy, because we're often using the same drugs to make the immune system do the same things. The point is, people with cancer are sick, but people with HIV on stable antiretroviral therapy essentially are not sick these days, and you don't want to do something that makes them sick. So you've got to be much more careful.
Yeah.
I'm hearing some interesting stuff about vaccines, preventative vaccines as well,
And they don't have to be 100%. I know, I'm just with the last press conference, yeah.
So that's very promising too.
And it's just a compendium. You have PrEP, you have treatment, you have condoms, and you have a vaccine maybe that's
I mean,
50%
Yeah,
or better.
well, yeah, that's true. It's one way of looking at it. I mean, my ideal vaccine would make the rest of it irrelevant. You know.
Yeah,
It
well.
my ideal vaccine would be 99% effective with one shot,
But we
and that
don't-
would be it. That would be the end of HIV.
But we're not there yet.
No, we're
but
not.
they will actually learn from that study. I think they'll learn from that study where who it's for, and maybe how to improve it.
Yeah, and even then, stigma will stop people taking it because we have a 99% effective vaccine against an STI that you can have that works pretty well with one shot, and that's the HPV vaccine, and people are still not taking it or allowing their kids to take it.
Yeah, that's amazing. That's amazing.
Yeah. Anything else you want to ask
No,
me?
I think you really covered a lot of it, and I appreciate it. I know that we talk about Steve Deeks and Sharon Lewin. They're two key people to do a really good job of explaining in the way you have. They're in the middle of the science. You're in the middle of reporting the science, but it's all good. It's all good because it gets us, our audience, informed about the possibility, and maybe it never will be. But
I did a cure education workshop in the Global Room with Sharon yesterday. So, and in fact, at the end, we were joined by Françoise Barry-Sanusi, who was just standing there watching us. So that was nice. But the community is going to need to write its own set of standards and expectations about cure research in the same way as we have done about treatment and about PrEP.
I mean, we're doing so well on antivirals, it's hard to say, okay, this is what we're going to do, and there's going to be some deleterious effects. And I'll just stay on the antivirals.
No, exactly. I had a row with somebody yesterday, a treatment advocate yesterday, who was saying, we shouldn't be spending money on cure research because HIV is already under control and we can bring an end to it with ARVs.
Well, there are people, the deep salvage, in small numbers, but those people out there that probably could use a cure.
Yeah, but I think a much larger number of people could use a cure because of the stigma. And it was
Yeah,
very
that's
interesting that the people at the Cure Workshop who came out most strongly in favour of wanting a complete cure were the African delegates. Because they said, we want something so that we can tell people we're HIV negative.
Well, we can want it and we can have it if we work hard for it.
Well, we'll get it eventually, though I think cure is much further away than the vaccine, personally.
Yeah, I think so. Gus, thank you very much.
Thanks, friend.
Appreciate it.